You want something? Go get it. Period.
But here's the thing, I didn't quit. I didn't fall back. I walked out of there to prepare for the next audition, and the next audition, and the next audition. I prayed.
But what is most important is that you have to dig deep down and ask yourselves, who do you want to be? Not what, but who?
Something you already know. The world ain't all sunshine and rainbows. It's a very mean and nasty place, and I don't care how tough you are, it will beat you to your knees and keep you there permanently if you let it. You, me, or nobody is gonna hit as hard as life. But it ain't about how hard you hit. It's about how hard you can get hit and keep moving forward. How much you can take and keep moving forward. That's how we get done. Now, if you know what you're worth, then go out and get what you're worth. But you gotta be willing to take the hits and not pointing fingers saying you ain't where you want to be because of him or her or anybody. Cowards do that, and that ain't you. You're better than that.
Inch by inch, play by play, till we're finished. We're in hell right now. And we can stay here, get the shit kicked out of us, or we can fight our way back into the light. We can climb out of hell. 1 inch at a time. On this team, we fight for that inch. On this team, we tear ourselves and everyone else around us to pieces for that inch. We claw with our fingernails for that inch. Because we know when we add up all those inches, that's gonna make the fucking difference between winning and losing. Between living and dying. I'll tell you this, in any fight, it's the guy who's willing to die who's gonna win that inch. And I know if I'm gonna have any life in it, it's because I'm still
everlasting, great or small, large or petty, never give in, except to convictions of honor and good sense. Never yield to force. Never yield to the apparently overwhelming might of the enemy.
You want something, go get it. Period.
All right, so today we're going to talk about goal setting. Can you give one to everybody? Don't open these until I tell you to. We're going to do a little exercise here. Oh, we got some people back there. Craig, Jay, thank you. Jeanette has this side. Just get that.
Oh, Jeanette's got that one. Ready?
Mr. Fred, don't get me on that camera.
Too late for that.
Do you need one?
Okay, does everybody have a piece of paper? All right. You will have, this is a 1-minute exercise. Does everybody have something to write with? No. You need something to write Share a pen. Everybody have a pen now? Okay, so here's our paper clip. You guys open up your papers. Everybody read your instructions. All right, so the minute starts now. All right, how we doing? Okay, ready, stop. Put your pens down. Okay, so the A group. I'm only talking to the A group right now. The A group. They all, if you notice, your pages said different things. There's an A, B, and C group. The A group for the paperclip said to do your best. How many items can you find and to do your best? So who got, how many, tell me how many you had. Did anybody have just one item? How many items did you write down for the uses of a paperclip? How many did you write down? In the A group, only in the A group.
2,
1.
So we got We have a 1, 1. How about a 2?
Yeah.
How many 2s? 2, 2.
3, 3, 2.
3 2s. How many 3s? 1, 2, 3, 4, 5. Okay. Huh? Only in the A group. 3. How many in the A group only had 4? In the A group only, 2. In the A group only, how many had 5? Anybody in the A group that had more than 4? And how many did you have? That's our overachiever. Okay. Alrighty, so in the B group, who's in the B group first of all? Just so you know, you can identify yourself. Okay. So in the B group, how many had just 1? How many had 2? How many had 2? Keep your hands up. 1, 2, 3, 4, 5. Okay, 5. 3. 4. And how many had 4?
They cheated.
Okay. In the C group, anybody have more than 4 in the A group? B group. Oh, B group. In the B group, anybody have more than 4? I understand. I understand. That's part of the point. Okay, the C group. Now, in the C group, how many? Who's in the C group first of all? All right. So in the C group, how many came up with just 1?
1.
You came up with 1? All right. How many came up with 2? Down here. I see your. How many came up with 6? 7. There we go. There's our overachievers. 8. 8 or more. Anybody?
Should have stopped at 7.
Should have stopped at 7. That's right. I did tell you to stop at 7. So what else? So everybody had different goals. So the A goal was do the best you can. Now is that really a goal? So this is a self-limiting goal, right? This is, whatever we think. And if you notice, the A group statistically got less than the B and the C group. They didn't have a measurable goal. Now the B's group was an easy goal, right? Just 4. Almost everybody made it. But they stopped there, right? So that's as far as we went. The C group had a very hard goal. And so some of them made it. Did some of you feel like, oh my gosh, that's too hard, and maybe I shouldn't reach for this goal? Those are the C group. How did you feel about that goal? Had to be creative. You had to be creative, that's right. You definitely had to be creative. So what does this tell us about goal setting?
That you can reach what you want.
You can reach the goal if you want to reach it, right? If somebody sets a goal that's measurable and you get immediate feedback, that you can reach it, that you can reach for it. But if it's not measurable, just the best you can, then you underestimate what you actually can do. Alrighty, we are going to start setting goals for the facility as a group. So we need to, so over the next, I'm going to show a little video now about healthcare and quality improvement. And over the next week, I want you guys to think about goals or areas that you feel like the facility could use improvement. And we're going to pick a couple of them and work on those as a group.
I'm Dr. Mike Evans, and today's talk is on quality improvement, or QI, in healthcare. So I suppose the first question is, why should you or I care about quality improvement? I mean, to be honest, it sounds a bit boring. Something a CEO would have on her or his corporate objectives. But actually, if you dig a little deeper, it's pretty cool. Maybe more of a philosophy or an attitude about how to make something better. And now that I think about it, it's really the attitude I'm looking for in my patients. The ability and desire to tweak their habits, seeing if this change improves their life, and if it does, to try and make it standard practice. You see, for my patients to make these changes requires skills, but it's also an outlook. The humility and self-awareness to say, I've got room for improvement. The ability to gather better approaches, try them on and see if they work, and then adapt them until they do. Well, if my patients can do that, I think they deserve the same from us in the healthcare business. So I suppose the next question is, if we have the attitude, how do we actually improve? How do we use QI to make care better? Well, the improvement business has been around for a while. Organizations like Toyota and Bell Labs and leaders like Walter Sheward, W. Edwards Deming and Joseph Duran polished and simplified the science of improvement. And then along came a pediatrician named Don Berwick, and he wondered if we could translate the science of building better cars or electronics to healthcare. Dr. Berwick also wondered if there were lessons about systems we could learn from the kids he saw in his clinic.
The systems thinker is a perpetually curious person who never thinks they have the whole answer, but is always willing to know what the next step to take is. If you watch a child, you'll see this happen. Children in their growth and development are innately systems thinkers. They're always trying the next thing. They're probing the material. They're listening to the noise. They're thinking about what the next thing to do is. And they're not in the job of solving problems forever. They're in the job of taking the next step. I think those are elements of what it means to be a systems thinker. At the core of it is constant curiosity about a world that you will never understand fully, but you might take the next step to understand a little better.
Okay, we've never dropped a vid into our vids, and Don is thoughtful, so I kind of thought it might improve our messaging. Let me know if you thought it did or didn't in our YouTube comments. Now, Dr. Berwick went on to co-found the Institute for Healthcare Improvement, or the IHI, and started focusing on the low-hanging healthcare improvement fruit, which is mostly reducing errors. For example, in Canada, a researcher named Ross Baker led a study in 2004 that showed of 2.5 million annual hospital admissions, about 13.5% were having adverse events, with 1 in 5 of those people dying or experiencing a permanent disability. In the U.S., the Institute of Medicine estimated that 44,000 to 98,000 people were dying from preventable errors every year. That's up to 4 jumbo jet crashes per week. Often these are errors we know how to prevent, but as is often the case, knowing what's the right thing to do and actually doing it are two different things. In 2006, Berwick and his colleagues challenged hundreds of U.S. hospitals to bridge this gap and felt strongly that some is not a number and soon is not a time, and so set the goal of saving 100,000 lives in 18 months. They started with this simple notion: every system is perfectly designed to get the results it gets. So how do you change the result? Well, you change the system that produces it. Changing the system requires change agents, and in my province we launched Health Quality Ontario. HQO and orders like it recognize that it's tough to balance proactive and reactive care in the field. But if they can help or incentivize or nudge us towards a more reflective practice and improve outcomes, we can actually create a better user experience for us all. Now, making this sound simple, like pushing a button, but getting people to change, even a simple behavior like hand washing, can be very complex and exasperating. But these seemingly small behaviors can have a ripple effect on health. A 2010 study calculated inadequate hand washing caused 247 deaths each day from preventable hospital infections, and that's just in the U.S. So let's jump back to simplicity. How to improve seems to boil down to 3 questions in a cycle. Improvement starts by setting a name. So question number 1 is, What are you going to improve, and by how much? So for example, we are going to get 70% of the staff to wash their hands before and after seeing patients by December 1st. Great, we have an aim. So let's start testing some changes, okay? Not so fast. Now you need to ask question 2. How will you know if a change is an improvement? We need to choose some things and measure them. What is doable and reliable, and that will tell us if the changes we are making are leading to an improvement? Is someone documenting doctor or nurse hand washing? Is it self-report? Is it the amount of soap and disinfectant used? Okay, we have an aim, and now we have some measures. Next up is question 3. What changes can you make that will lead to the improvement? To start, we just want to test one change with something called a PDSA cycle. Plan the test, do the test, study the test results, and then act based on those results. Maybe it's new soap dispensers or little bottles of gel. Maybe you read about the study that changed the signage from wash your hands to protect yourself to wash your hands to protect your patients, which resulted in a 3rd improvement over a 2-week period. Maybe it's reward or audit and feedback or asking patients to check. Just pick one and get started. Then you test other changes and the PDSAs just keep rolling. Fine-tuning the change based on what you're learning. Saying to yourself, here are some ways we can improve. Let's try them out by dropping them into our practice in a thoughtful way that fits with our clinic and our patients. Well, let's measure how we do. Adapt, adopt, or discard. Simple, right? But powerful, and it actually works. In my hospital, St. Michael's in Toronto, elderly patients with fractured hips were often waiting more than 2 days for surgery. This wait was painful, with increased chances of conditions like delirium and depression, longer recovery times, and even death. The care team scratched their chins, mapped out and redesigned every step of the journey to surgery in order to fast-track these patients. They created a code HIP called as soon as the patient arrives. This streamlined them to the urgent list for surgery, rapid triage, essential testing, priority consults from anesthesia and internal medicine, and so on. All of these tweaks led to a jump from 66 to over 90% having surgery within 48 hours. Now, these changes don't happen without engaging the human side of change. One thing you'll discover is that it's possible that the people you work with might not be as into hand washing or urine infections or diabetes as you are. I know, crazy, but this leads to 3 pieces of advice. First is the concept of innovation fatigue. Often your workmates are getting overloaded with requests for practice change, which are well-intentioned but can be overwhelming. My own approach is to take a page from motivational interviewing. MI recognizes some of our natural inclination as problem solvers is to fix things, provide advice, and argue for change. But the reality is that not everybody is ready for change. Both MI and QI recognize that ambivalence about change is normal, that building readiness and confidence for change, a shared agenda, requires careful listening and strategic questioning, the ability to roll with resistance, more of a dance than a directive, I would say. Actually, sometimes resistance to change can actually be an opportunity in QI. Creating diversity or disruption can actually be an opportunity, something to build on. My second point is about priorities. I think we have to acknowledge that patients and your fellow clinicians may have certain priorities on the day. That talking about depression or headaches may trump your diabetes flow sheet, or even that focusing on their non-diabetes issue might in fact be more helpful for patient self-management. These shifting sands that transition from siloed care are the reality of the emerging science of complex care. Sure, asking what's the matter, but also asking what matters to you. A great example is in Timmins, a small town in rural Ontario, where they wondered if they could do a better job of handling complex patients in the emergency department. So people seen in the emergency more than 14 times or admitted more than 3 times a year. They started with standard assessment tools, identified diagnoses and related problems, generated care plans, but unfortunately patient use didn't decrease, to what's called patient discovery, where they identified health and lifestyle challenges from the patient's perspective and combined that discovery with motivational interviewing techniques. This new patient-centered approach resulted in more than an 80% reduction in emergency room use and admissions. Finally, after having done many interventions, my mantra is, how can I make it easier to do the right thing? Maybe easier is about sharing the load. At Kaiser Permanente, front desk staff can actually check and book for preventive screening. Everyone can help in QI. All these point to the softer side of good quality improvement. That when we look at the science of innovation, it's less about big cognitive leaps and more about agility, small incremental steps that build on the ideas of others and engage our own genuine curiosity regarding what motivates and inhibits the individual and system's path to change. The main point is, start. Find something you can improve and get going. Look, it's hard to summarize improvement and not get into bumper sticker territory, but I would advise not to let what you can't do stop you from what you can do. It's time to entertain complexity, but focus on simplicity. Asking yourself, what can I do by next Tuesday? Have a meaningful needle and test some changes to start moving that needle towards an important goal. Hope this helps, and thanks.
Thank you to the Ontario Healthcare Systems. Alrighty, so what kinds of things do we learn there about performance improvement and quality improvement?
We all have a part of it.
We all have a part in it, that's exactly right. I want our new mantra to be, if you see something, say something. In other words, if you see an area that could use improvement, if you see something that we could do better, say something about it. We all want to we all need to give input, we all need to talk about it, we all need to, and we do have a suggestion box, or we can bring it to this meeting. I want it to be something that we all work on together. We're not looking at pointing fingers at anybody. We're looking at systems. We're looking at systems. We need to look at the system and figure out how that we all can grow and we all can make it better. Because only the system's help this is going to make it better. What else did we learn?
Keep it simple.
Keep it simple. All right. What else?
Patience. Patience.
The patient's point of view. That's very, very important to keep in mind, especially when we're working out priorities for our goals. What's most important to the patient? Yes, Vera? Small changes make big differences. That's exactly right. Most definitely. What else we got? Alrighty, so you have a homework assignment from this one. So for next time, we're going to be talking about what we do well and what we can improve upon for the village's rehab and what kind of goals we can set. Thank you, folks. Have a great day.